Welcome everyone again to another episode of the ideaXme show, the show that profiles the humans behind the really big ideas that are shaping our world and inspiring the future and future creators. I'm Ira Pastor, your life sciences ambassador along for the journey today. So here we are a few months into the COVID-19 pandemic, and a medical term that we've been hearing mentioned in the popular press quite a bit in terms of the pathology of this infection is that of cytokine release syndrome. Also, we hear it termed cytokine storm syndrome, which is a form of a systemic hyper-inflammatory response that is triggered not just by infections, but can also be triggered by certain drugs, antibody therapies, and so forth. It typically occurs when large numbers of white blood cells are activated. They release so-called inflammatory cytokines, which are a range of proteins that are involved in cell signaling, which in turn activate more white blood cells, and turns into a very dangerous cascade, which can harm and ultimately kill patients, leading to hypotensive shock, multi-organ failure, and so forth. Just a few months ago, the Springer Publishing Organization released a text entitled Cytokine Storm Syndrome, and this is the first of a kind book that really addresses all aspects of this very unique disorder, from the genetics to the pathophysiology, research, risk factors, treatment, and so forth. We're really honored to have one of the co-authors of that book joining us today. Dr. Randy Cron is professor of pediatrics and medicine at the University of Alabama at Birmingham and the Arthritis Foundation Alabama Chapter Endowed Chair in Pediatric Rheumatology. Dr. Cron is also the director of the Division of Pediatric Rheumatology and Pediatric Rheumatology Fellowship Program at Children's of Alabama, which is a private, nonprofit hospital that provides specialized care for ill and injured children. Dr. Cron received his medical degree from UCLA. He also has a doctorate in immunology from the University of Chicago with pediatric residency training at Stanford Children's Hospital in California and pediatric rheumatology fellowship training at Children's Hospital Medical Center in Seattle. Dr. Cron is board certified in pediatric rheumatology. He's the past president of the Alabama Society for Rheumatic Diseases, a member of the American Academy of Pediatrics, Society for Pediatric Research, American Association of Immunologists, American College of Rheumatology, and numerous other professional organizations. He has wide-ranging research interests, including the dysregulation of CD154 protein, which is expressed in T cells in lupus, which we'll get to a little later in the show, CD4 T cell host factor regulation of HIV, transcriptional activity, a variety of other focuses, but very importantly to discussion today, he is focused on the diagnosis and treatment of macrophage activation syndrome, which is a subset of what we're talking about in terms of cytokine storm syndrome, which is a severe, potentially life-threatening complication of rheumatic diseases in children. All that being said, Dr. Cron, thank you for taking the time out of your schedule to come on the show today and talk to us for a while.
Yeah, thank you, Ira.
Yeah, it's our pleasure to have you, really. I mean, this is such a timely topic. Typically, we start off the show, we give our guests the floor for a little bit just to talk about themselves. If you could just take a few moments to go into your backgrounds, or where you grew up, how you got interested in medicine and rheumatology, and how you sort of developed this focus on this extremely important topic of cytokine storm or cytokine release syndrome.
So I grew up in Southern California. Didn't have medical people in my family background. My mom's side of the family, including my grandmother and my mother, both my sisters were teachers. My dad was a chemist. But like a lot of kids kind of graduating high school, I wasn't exactly sure what I wanted to do. I had a strong interest in journalism, actually, and computer science was starting to get going at that time. But actually, my biggest interest was in playing water polo, as a lot of Southern California kids did. And so I ended up going to the University of California at Riverside to play water polo. And I think my mom was prescient or something, but she thought, that school had a program that kind of took you from undergrad in through medical school, ultimately at UCLA, in a 7-year process, if you kind of made the cut. But it was a way to get students to go to school there. Now it's, 4 times the size of the population when I went to school there. They have their own medical school, so that's all changed. But anyway, she suggested I enroll in that major, which is biomedical sciences, and head my path into the medical world, which seemed fine. I like science. but I still had all these other interests. But anyway, so I went to school there and kind of made the cut. But in the process of starting my first year of medical school, which actually it was at UC Riverside, my immunology professor kind of really got me interested. Like a lot of medical students, particularly in the first few years, and I know it's changed a lot since I was in medical school, but it's a lot of memorization, which most of us are good at, but it's not always that thrilling. But when he started, this was Dr. Carl Ware, discussing the immune system, I got excited. Just the fact, particularly that type of white blood cell, your T lymphocytes and your B lymphocytes were able to rearrange their genes. That in and of itself just kind of blew my mind. We have our genes and we're pretty much set, but this was a part of our genome that actually lymphocytes can rearrange and develop all these multitude of different receptors so that we can recognize these foreign pathogens, including things like COVID-19 at some point, right? Anyway, so he was like, like a lot of people, like most people, I think, in whatever profession they're in, they're influenced by people along the way. And I think Dr. Ware was one of those people for me. Mm-hmm. Also, during my second year of med school, he said, there's this program, I think it was the second year of the program, that's being funded by the Howard Hughes Medical Institute to get medical students without a research background, myself included, interested in doing research. And so this program was actually set up at the National Institutes of Health. Mm-hmm. And so I applied for that and was lucky enough to be accepted into that program. And so I went to the National Institutes of Health and met some other really incredible immunologists. For example, William Paul is just one of our major all-time great contributors to the field. And he was actually my mentor to try to guide me into a lab for a year under this Howard Hughes funding to see if this was something I wanted to do. And he had a choice of a lot of fabulous people like Ethan Shevack, for example, but I ultimately ended up in Jeffrey Bluestone's lab. He was a young investigator at the time. It was himself, a technician, and a postdoctoral student, actually, who was the first pediatric rheumatologist I ever met. And at that time, I didn't know I was going to pediatric rheumatology, but Rafi Hirsch was there doing his pediatric rheumatology fellowship in the DC area, but was also working in Jeff's lab. So it was a small lab. Jeff is now hugely well-known, famous, phenomenal immunologist. Anyway, and so Jeff probably has had overall on my scientific career, probably more influence than anyone. He continues to be a mentor and colleague for me. I owe him a lot. Mm-hmm. He was not that much older than me. I also kind of considered him as like a big brother. I lived with him for a while when we ultimately moved to the University of Chicago. So anyway, so that year really flipped my life. And so thanks to Dr. Ware, I was aware of that program, and then thanks to Howard Hughes and the NIH for providing it for medical students. Mm-hmm. And it definitely worked for me. Like the goal of that program was to get interested people in medicine interested into science. Right. I had a very productive 3 years with Jeff, better than I could ever imagine, but it really, more than anything, turned me on to science, particularly immunology. And actually after, so what ended up happening is I had asked Howard Hughes for a second year because I was so excited about what we were doing, and they were kind enough to give me that funding. But then Jeff was kind of outgrowing the confines at the NIH, and so he took a position at the University of Chicago, and I was the only person who went with him from his lab. And Frank Fitch, who was the dean at the University of Chicago, another phenomenal immunologist, suggested, you already have 3 or 4 papers published. Why don't you just get some classwork done and we'll give you a degree? And so that's what happened. And so that was kind of the beginning. But at that point, after getting my PhD, I had to decide, okay, do I go back for my last 2 years of medical school, or do I go do a postdoctoral fellowship in an immunology lab somewhere around the world? And that was actually a hard decision for me. But I ultimately came down to, it's not going to hurt to get a medical degree, and I don't have to use that to treat patients if that's not what I want to do. Mm-hmm. And it does open up a lot of doors. Anyway, so I did go back. UCLA had been kind enough to keep deferring my years of absence. They had a pretty large medical school class, so I was a relative small drop in the bucket. And so I returned and finished medical school at UCLA. And during that process, on my pediatrics rotation, which was at Harbor UCLA hospital in Torrance, one of the county hospitals, I fell in love with pediatrics. It just made sense to me. I like taking care of the kids. The kids were victims of their disease for the most part, you know. On medicine, like a lot of medical students experience, you would often see the same patients kind of rotating through the hospital, a lot of times from either overeating, over drinking, whatever it was that they were doing, smoking, IV drug abuse. And I felt like a lot of times we were helping these people, but they were just coming right back in, and it was less satisfying, I guess. Anyway, so like a lot of pediatricians, we migrate to the kids. And so that's how I got interested in pediatrics, was from that rotation. And then there's no perfect timing for this either. So then I went on to do a residency in pediatrics in Palo Alto. And there I met Jack Miller, who was a pediatric rheumatologist, who was one of the godfathers of pediatric rheumatology in this country. It's not that old. Like, it's been in the US kind of since the 50s, 60s-ish. And Jack Miller was one of those early important individuals for the field. And so because I had this background in immunology, rheumatology seemed like a natural fit. There are pediatric immunologists, and they treat a lot of kind of primary immune diseases, you know, genetic disorders. But the rheumatology seemed like it was really more immunology, you know, because this is the immune system attacking itself in a lot of these autoimmune diseases. And now we have these autoinflammatory diseases, which gets back to the genetics too. So kind of more the innate immune system problem than the adaptive, with the T cells and B cells. Anyway, so Jack Miller was a big influence on me, and he actually recommended the various places I look at to do a pediatric rheumatology fellowship after residency. And I ended up in Seattle, where they had kind of designed their fellowship at that time when the ACGME would allow this kind of thing, where it was really, although it's a 3-year fellowship in pediatrics for essentially all the subspecialties, the way Chris Wilson, who was kind of head of the program up there for, he's an immunologist, infectious disease doc, had set it up so that the fellows would do only really 6 months of clinical work and really focus on the research. And so that was very attractive to me. University of Washington's a fabulous place as well, great immunology up there. And it turned out that that 2 of the pediatric rheumatologists who were in that program, Carol Wallace and David Sherry, were some of the best clinicians I've ever met. And so it was a bonus of having great science and kind of set up to be a science-based program, and but at the same time getting fabulous clinical training. They're pretty aggressive in comparison to some of their colleagues across the country. Pediatric rheumatology is a pretty small subspecialty. There's probably less than 300 of us practicing in the country. And so a lot of what we do is kind of seat of our pants. We don't have necessarily, or we didn't back then at least, a lot of randomized trials, kind of the gold standards for how we should be treating kids with various rheumatic diseases. And so anyway, so those 2 people were also incredibly powerful influences on my career. And the lab I chose was David Lewis, who is a pediatric immunologist who's now at Stanford. And the great thing about Dave, well, he's also, you know, brilliant like Jeff Bluestone is. But Jeff taught me a lot of mouse immunology, because that was what he was doing at the time I was in his lab. And he taught me a lot of cellular immunology, how the cells interact and how to assay that kind of stuff. But Dave Lewis was more of a human immunologist in terms of the science. So we studied actual human cells and related them to various diseases. And he taught me a lot of the molecular aspects that I hadn't learned during my PhD. So a lot of tools for my research toolbox, which was good. And during my time in his lab, like you mentioned, I got interested in this protein CD40 ligand, or CD154, because it was being shown to be overexpressed by Peggy Crow and others in lupus patients. And we were studying the regulation of that gene and how, you know, you control it and how it may be dysregulated in lupus. And that actually was a large part of my early scientific career when I ultimately ended up at the University of Pennsylvania to start it off. But I also got interested in HIV through transcription, kind of serendipity. I actually went to there are many lectures you can imagine you can go to at universities, and I went to a lecture that Seymour Klebanoff was giving, another kind of outstanding scientist, particularly in the world of HIV. And I realized I was in the wrong lecture hall, but I was kind of trapped by people on either side of me. So okay, I'll listen to, you know, he's a member of the National Academy of Science, I'll listen to Seymour. And he put up this slide during his presentation that showed the transcriptional promoter of the HIV virus. And at that time, I had been studying transcriptional regulation of CD4 ligand and IL-4 and some other genes, and noticed kind of in my mind's eye so DNA is double-stranded. The other strand in my mind's eye was a good binding factor for this transcription factor family called NFAT, NFAT, which is actually the protein of the transcription factor that's primarily regulated by some of the drugs we use, calcineurin and FK506, for example, often used in transplant to prevent rejection, for example, as well as in autoimmune disease. Anyway, so that blew my mind. And so myself and others got interested in the ability of this NFAT transcription factor to regulate HIV. So that's how I got into some of my HIV research. So then Dave Lewis took a position at Stanford. And so once again, I was the only person to go with him and help him set up his lab and get established there. And I was fortunate enough to once again get money from Howard Hughes Medical Institute and kind of a postdoctoral fellowship, which also gave me time to do, get my feet underneath me so that ultimately when I started a lab, that would be, helpful.
Mm-hmm.
And at Stanford, things went well. I got some small grants there to take with me wherever I went. And Betsy Mellons is a pediatric rheumatologist there and also an outstanding immunologist. She had actually trained in Seattle as well. And she suggested that I look at the Children's Hospital of Philadelphia / University of Pennsylvania.
Mm-hmm.
And so at that time, they were kind of revamping the division. And Terry Finkel was kind of my next primary mentor at that point. And she had come from the University of Colorado, also an outstanding immunologist. She actually did HIV research, worked on T cells, so it seemed like kind of a natural fit. And so I joined her, and once again, we kind of started a division from scratch. She took the bulk of that on her shoulders because she was much more senior in terms of her academic career than I was at that point, and she protected me so that my career could take off. And then at some point, we were incredibly lucky enough to recruit David Sherry, this clinical guru from Seattle that had trained me, to come join us in Philadelphia. And that really took a heavy weight off our shoulders there in terms of being able to stay in the lab and stay focused there. But it also allowed us to set up a training program or fellowship program to train more pediatric rheumatologists at the Children's Hospital of Philadelphia. And we had a run of phenomenal physicians and physician scientists come through that training program, including this dynamic duo of Ed Behrens and Tim Buchelman. And Ed and I were on clinical service at one point and got called to see a 14-year-old girl with a horrific underlying disease that she'd had really since infancy. But unfortunately, as part of that disease, she could develop these cytokine storms, or what we were calling macrophage activation syndrome back then.
Mm-hmm.
And we were called to see her in the hospital. At a point, she was incredibly ill. For me personally, she was probably the sickest patient that I have ever personally taken care of, who came out of the ICU essentially unscathed. She was about as close to death as you could come. Mm-hmm. She was in liver failure, renal failure, heart failure. She had acute respiratory distress syndrome. Her lungs were failing. All her cell lines, her platelets, white cells, red cells were all gone. She had pancreatitis. She was being supported by what we call inotropic or pressor support to keep her blood pressure up. And she was intubated, obviously, because of her lungs. And and her central nervous system was involved. She was inflamed. It was scary. And around that time, this is in late 2004, there was, so let me back up a little bit. So as pediatric rheumatologists, we treat this one disorder called systemic juvenile idiopathic arthritis, or SJIA for short. Sure. And the adult equivalent to that is called adult onset still disease. It's very likely the same disease, just happening in adults. Anyway, those were a subset of our patients that we didn't have great therapy for. But people like Virginia Pasquale in Dallas at the time had started realizing that blocking interleukin-1, one of these pro-inflammatory cytokines or hormones of the immune system, was beneficial for them. And so we had started treating kids with this drug, and it was phenomenal, right? And the thing is those children with systemic JA, for whatever reason, we think partially genetic, but partially just the way their disease manifests, get recurrent episodes of cytokine storm.
Okay.
And so it made sense to Ed and I, at least, that maybe this girl would benefit from that because she was having a cytokine storm and this drug worked for that. The drug is actually a recombinant human protein, so a protein that your own body makes.
Right.
And it's called an interleukin-1 receptor antagonist. So really, it primarily just sops up excess IL-1 and keeps it from signaling through IL-1 receptors. And so in that sense, it's a remarkably safe drug, actually. It doesn't target cells like essentially almost all other drugs other than maybe antibiotics do. And it had a lot of safety data because it was thought to be maybe a good drug for rheumatoid arthritis, and it's approved for that. It's not necessarily the first drug that adult rheumatologists will go to. But anyway, there's a lot of safety data. It's got a very short half-life of about 4 to 6 hours. When it works fast. And it can be given subcutaneously or intravenously. There's just a lot of reasons why this seemed like, in this child who was dying, the potential benefit to side effect ratio was very high. It's also got a huge therapeutic window, we now know. And so anyway, we used a relatively low dose in her at that time compared to what we're using today. We talked to the family, we talked to the other physicians who were treating her. She was already failing kind of a chemotherapy-based approach that the pediatric oncology, hematology world had used for a long time with the etoposide or BP16 and high-dose steroids and cyclosporin. And she was worsening. And so this is why we tried it. And that patient really flipped my world. I think it flipped Ed's world too. And within 2 days, she woke up from her coma. Within 6 days, she was out of the intensive care unit. Within 2 weeks, she was out of the hospital. And it was nothing short of miraculous. And it really just flipped my research. You know, I had gone as a medical student and a resident to a lot of ground round talks by other physicians, some, you know, phenomenal physician scientists, and they would often start their career talk with a patient or a couple patients. And I would just sit there and dream, like, maybe I'll get a patient where that will guide my research. And this was that patient for me. And Ed too, so Ed actually went on to develop a mouse model of this disease because it's much easier to study aspects of the disease in mice. Obviously, you can manipulate them, genetically manipulate them, treat them. You want to do it safely and to Aya cook and all that stuff. But you can really learn a lot from the immunology of mice. Anyway, so that's like the basis for now Ed's career. He's stayed on at the University of Pennsylvania, and so anyway, so that was really what I think drove me into the field of cytokine storm syndromes. I think we should give a shout out to like a lot of people in this field. There are people way beyond me. I consider myself more of a cheerleader for this disease because I'm okay to give attention to it. And I think one of the silver linings of this COVID-19 pandemic is that, we're not only educating the public, but other physicians who may not even know about this. It's if you look in the PubMed literature, there are only 4 papers through the 50s and 60s. Now there are close to 8,000. And the first gene wasn't even identified until 1999, or reported in 1999, which was perforin. But anyway, there are people, Jan Inge Henter in Sweden, Grita Janka, Lisa Filipovich, many kind of pediatric hematology oncology folks who took care of the primary forms of this disease, who we stand on all their shoulders. But there's a lot of people today that is doing just phenomenal work as well. From Michael Jordan to Carl Allen to Kim Nichols, Angelo Ravelli, Alexi Grom, Yenin Bryson, Fabrizio Di Benedetti, and even some of our ICU colleagues like Joe Kirkillo in Pittsburgh, Kai Lemberg, the list goes on and on. Young folks like Scott Canna and Grant Schulert and Lauren Henderson. I mean, it's a phenomenal small world at this point, but I think, we've all contributed our pieces to the pie.
But, one thing that, comes to mind when I do sort of read about macrophage activation syndrome, the sort of this sister condition, I know I'm going to say this wrong, hemophagocytic lymphohistiocytosis. I think about all of these sort of catastrophic, cascade type things that happen in humans in terms of things like sepsis and anaphylaxis and so forth, where sort of in my mind this sort of falls. Is there? I mean, before we get into some of the some what you're learning in terms of treatment and dealing with these patients. Is there some sort of evolutionary basis behind why? I mean, this is sort of, you look at autoimmune conditions, and this is the far end of of everything, right? I mean, it's an all-out assault that happens for some reason. Is there sort of, if you guys sort of study why this happens in the first place? I mean, it seems such like a, I don't know, it's ancient, but something that you would, you think about sort of in evolutionary context, like this would be the way sort of the immune system would deal with things like a long time ago versus how our immune system should be working today, and sort of why with something like COVID, which we've never seen, or our immune systems have never seen, why something like this bubbles up. If you can go into that, that'd be great.
Sure. So just talk about, what we think cytokine storm syndrome is, or what the components of it are. I like to, it was just timely. We didn't see this pandemic coming, Dr. Behrens and I, and we're just the editors. We wrote a couple chapters, but a lot of those people I mentioned wrote some phenomenal chapters in that textbook. I don't see a dime from the sales of it, but it's still a really useful textbook. But so we chose that word, cytokine storm syndrome, in part because, once again, I think we need to make it known, not just for other physicians who may not have learned about it at all if they trained a while ago in medical school, for example,
sure,
to the general public, because cytokine they're probably not familiar with, but they can learn about pretty easy, right? Sure. It's these proteins that are hormones of the immune system.
Right.
Some actually produce more inflammation. Some try to dampen it down in simplistic terms.
Mm-hmm.
And storm, people know what that is, and syndrome, people have heard that. And so we kind of use it as an umbrella term that underneath there are multiple different entities, including macrophage activation syndrome, which the rheumatologists name for conditions like lupus or this Still disease, systemic JA, who frequently get cytokine storms compared to other types, but it can occur in almost any rheumatologic condition you can imagine, unfortunately. And then HLH, or this hemophagocytic lymphohistiocytosis, which there's a genetic or familial form, which has taught us a lot about the pathophysiology of this.
Okay.
Hasn't taught us everything, because there are actually multiple routes to get to a cytokine storm syndrome, but the genetic ones we probably learn the most about. And then there's this cytokine release syndrome, which occurs in cancer patients.
Okay.
So patients with leukemia and lymphoma, for example, they can get a cytokine storm independent of treatment, unfortunately, but they can also get it as therapy for refractory or very difficult to treat leukemia with things like CAR T-cell therapy, like you mentioned. And so that's another entity. And then probably the biggest bubble under this are the infectious triggered associations of what we call secondary HLH or acquired HLH. And there are probably over 100 organisms that have been described associated with it, some certainly more than others. So the most notorious agent we know of is the Epstein Barr virus, or EBV, which can cause mononucleosis, among other things. But it tends to be the most commonly associated virus with infectious triggered HLH or cytokine storm. And members of that whole family of DNA viruses, including cytomegalovirus or CMV or herpes simplex virus, they're all kind of major contributors. Other viruses like bad strains of influenza, like 2009 H1N1, and we can talk about that a little bit later maybe,
sure,
can trigger this as well as bacteria, parasites, fungi. There are a whole slew of triggers, and we have actually independent chapters in our textbook on the various different types. And then, the other thing that people may be aware of are these hemorrhagic fever viruses like Ebola, likely is triggering a cytokine storm that's leading to the demise of those individuals as well. Dengue. Not a lot of people in the US may know what dengue is, but there are millions of people infected around the world, mostly in Southeast Asia. But 500,000, I think, people per year come down with like hospitalizable sick dengue, of which probably a large percentage have a cytokine storm as part of that. So once again, a silver lining from this pandemic may be not only just teaching people and helping people with a cytokine storm as part of their COVID-19, but just people succumb to cytokine storms all around the world, all age groups, children and adults, in intensive care units all over the planet every day from a variety of triggers and associated factors. So, so why let me see, get me back to the original question. Was it, why is it that this occurs in some people, or I can't remember exactly your question.
Yeah, I mean, this seems like a, well, it doesn't seem like it. It's sort of this all-out assault, or sort of the immune system is not trying something that stimulates this or that gene, but letting everything go at once. Yeah, is there some evolutionary context here of why, of why this happens in this way?
Yeah. Thank you for refocusing me there.
No, it's fine.
So, like I said, we've learned a lot from the genetic form of this disease, which fortunately only affects about 1 in 50,000 live births, but that's still a fair number of kids. They have a very severe form of this cytokine storm that presents in infancy typically. It can present beyond 1 year of life, but that's pretty uncommon. It usually presents within days, weeks, or months of birth, and may be triggered by a virus, maybe not. And these infants have homozygous, so both chromosome copies of whatever gene is affected is altered in a bad way on each chromosome. So they tend to be these autosomal recessive disorders where you have a mutation, for example, in perforin on both chromosomes. And the perforin is a protein that certain white blood cells or lymphocytes, namely natural killer cells or NK cells, and cytotoxic CD8 T cells or CD8 T lymphocytes use to actually kill, for example, infected target cells or antigen presenting cells. And so if you're a cell in the immune system, for example, like a dendritic cell or a macrophage, it's been infected by one of these viruses, and you're trying to present this virus to your adaptive immune system, your T cells, for example, so that you clear that virus. One of the roles of the natural killer cells or the cytotoxic CD8 T cells is to recognize that infected cell and kill it. And that kind of shuts down the viral life cycle to some degree. And what happened, and so perforin is this protein that when it gets released into this, they call it the immunologic synapse, this kind of gap, very close, we're talking small measurements here of the T cell and the infected cell. For example, the perforin actually forms a channel or pore between those two cells, and then the killing cell, the lymphocyte, will then deliver proteins like granzymes, which then trigger the other cell to die by apoptosis typically, which is kind of programmed cell death, something that's kind of hardwired into a lot of our cells. And in that process, there is some stimulation going on so that some of these cytokines are produced, whether it's interleukin-1 or gamma interferon or tumor necrosis factor, interleukin-6. You've probably heard some of these terms by now. And they get produced, and that's normal, right? That's part of the normal immune response. But what we know happens, at least in these infants, as well as in mice in which you can genetically manipulate them so that they lack these proteins, just like in the human scenario. And it's important to point out that it's not just perforin, but there is a whole list of proteins that are important for delivering this perforin-containing granule to the immunologic synapse from within inside the cell. So these proteins help traffic these cytolytic granules that contain perforin and granzymes to the synapse. And they have a bunch of unusual names like RAB27A, MUNC13-4, Syntaxin 11, et cetera. But they're all critically important in the process. So it doesn't have to be perforin. It can be any of these other proteins that are important in that pathway that are defective on both chromosomes that basically lead to the same result. And that is the T cell or the NK cell is incapable of killing the target cell through this perforin pathway. And what a really nice paper from Misty Jenkins and colleagues, I think came out around 2015 in the Journal of Experimental Medicine, which kind of directly demonstrated this concept, where they took cells that were deficient in granzyme or deficient in perforin and put them together with the cells that they were supposed to target or lyse or kill. And they noticed that they stayed, because they couldn't kill through this perforin pathway, they stayed engaged on average 5 times longer than they normally would. If your immune system has a normal response, the NK cell or the CD8 T cell will kill that infected cell and then move on. And some cytokines will be made, but not overly exuberant amounts. But what Misty Jenkins and colleagues showed is that these lymphocytes stay engaged with this antigen-presenting cell 5 times longer than they normally would. And in that process, they spew out extraordinary numbers of gamma interferon, TNF, whatever. And that's what gets the patients into trouble and may ultimately lead to this acute respiratory distress syndrome that we sometimes see, which is really dominant in COVID-19,
Right.
or other multi-organ system failure, including the liver. And so from these children and from mice modeling these children essentially in these various pathways involved in perforin-mediated lysis, we've learned an immense amount about that particular route of getting to a cytokine storm. There are other routes of getting there through inflammasome activation and a variety of other genes that we're just really starting to learn about.
Got it.
So the familial form of HLH has taught us quite a bit about that particular aspect, and that may be one of the most common ways that we get there. And the reason I say that is, okay, that's 1 in 50,000 live births, and no one really knows how common cytokine storms are in general. There are guesstimates that maybe 1 in 3,000, maybe more individuals may develop a cytokine storm at some point later in life, whether it's in childhood or in adults, if they get the wrong trigger. And there's a threshold model where, let's say you have a mild genetic predisposition, you're in an inflammatory state, for example, if you have systemic lupus, for example, and then something triggers it like a virus. And you get over that threshold where your immune system is no longer able to keep things under control. And so in looking at patients who develop this later in life, whether it's children or adults, and this is controversial, but it's what I believe, and it's what a lot of my colleagues believe, but not everyone, is that some of these secondary forms have single copy, or what we call heterozygous, so one chromosome mutations in these same proteins, as well as some other proteins, but in the same perforin pathway. And so normally if you have one bad protein, like a cystic fibrosis protein, and you have one good, you're okay. You're not gonna, because the other good copy is going to help you out, and hopefully you won't develop cystic fibrosis. But for this disorder, for some of these mutations, not necessarily all of them, but for some of them, they have either what they're called hypomorphic effects. You don't make enough. You need a certain amount of this protein for this pathway to work correctly. For example, MUC13/4, that might be the case. Or they act as what we call partial, or sometimes even rarely complete dominant negative proteins. In other words, having one good copy is completely trumped by having a bad copy. It disrupts the pathway by having, because maybe they're, in homodimers or trimers, and so having one bad part of that complex messes up the process. And so, like I said, it's controversial, but I think there's enough evidence out there that patients with secondary forms of this disease have mutations in these same genes that the familial patients have, but at a higher percentage than you'd expect in the general population.
Interesting.
And in terms of what's tolerated, and this makes sense kind of, in terms of evolution, why is it that most people do fine even if they have these mutations? Well, they may just not have gotten the wrong trigger, in this case maybe COVID-19, or what we know in the past for various strains of influenza. And so certainly some of the milder mutations in these pathways, which we still think have very partial effects, for example, on the ability of these NK cells or CD8 T cells to kill their target. They can still kill, they just don't do it quite as well. And they probably stay engaged, not necessarily 5 times longer where they're completely deficient, but maybe 2 times, right? Or whatever it happens to be, is giving this excess cytokine. And so, for example, in 2010, there was a publication by Paul Harms and colleagues. He's a pathologist at the University of Michigan. And in 2009, we had a world pandemic of the H1N1 influenza strain. And that killed a fair amount of people around the world. And some of these people were previously healthy, for the most part, 30, 40, 50-year-olds, some are like what we're seeing now with COVID-19. And they noticed on the pathology specimens that they had this feature of hemophagocytosis, and this is where this name HLH comes from. And hemophagocytosis are these activated macrophages or histiocytes that engulf other cell types, including other white blood cells, red cells, etc. And it's kind of a hallmark feature for cytokine storm syndromes in general, although I will say that it's only present about 60% of the time, so it's neither perfectly sensitive nor perfectly specific, but it certainly makes you think that way if, in the setting of someone who's very sick with a fever. And so anyways, I saw this report where they showed, these hemophagocytes all over the pathology, and so I contacted Dr. Harms, and he was kind enough to share whatever remaining kind of pathology specimens we had available, just so we could do the genetics on them. And I kind of brokered this through some of my colleagues, Alexi Grom and Grant Schuler at the University of Cincinnati, because they were doing a lot of the genetics on these patients. And it turned out that it was a small group, it was 14 patients, but that 5 of them, or 36%, had a mutation in one of these perforin pathway genes list. And these were mostly missense mutations, so changing one amino acid to a different amino acid.
Okay.
And 2 of those patients also had probably one of the most common mutations, but we still think is functional, is a perforin mutation called A91B, another amino acid change. So it kind of confirmed this concept that you're probably at higher risk for developing a cytokine storm if you have one of these partial dominant negative or potentially hypomorphic mutations that disrupts this pathway even to a mild degree.
Fascinating. Really fascinating, and the complexity of this this biology. And I suppose people don't really think of the immune system in this context, but it's really a in many ways an uncharted frontier when it comes to some of this. It's really just listening to you go through the intricacies of it and how much is involved in keeping us safe or trying to keep us safe from invaders is really fascinating stuff. Could you, from there, I know, COVID is not a rheumatic condition, but could you talk briefly about how cytokine storm leads to, as you mentioned, the acute respiratory distress syndrome? Is ARDS a cytokine storm of the lungs, or is it something that comes afterwards? Can you just talk a couple about how that interfaces in terms of the deaths and the pathology we see with COVID?
Yeah, it's a really good question. I am not a pulmonologist or an intensivist. I don't consider myself an expert on acute respiratory distress syndrome. And I've actually even heard there's some people who think that this isn't exactly the typical ARDS that we see in like sepsis patients, for example.
Okay.
But it sure has enough features with it. And as I kind of alluded to earlier, COVID-19, unlike most of our cytokine storms, really starts in the lung.
Okay.
Most of our other cytokine storms, the lung is a late finding or a later finding than in COVID-19. And maybe it's just because of the tropism for the virus for the lower lung. No one knows. But yeah, I mean, and the term ARDS or acute respiratory distress syndrome, when we draw our umbrella, where we include MAS and HLH and cytokine release underneath that umbrella, and you make Venn diagrams of these overlapping bubbles, right. ARDS certainly overlaps many of the cytokine storm syndromes, but it can occur in the complete absence of that as well. So I don't want to think or give the impression that ARDS is always a cytokine storm. But in the case of COVID, it certainly seems reasonable that it may be part of this more systemic inflammatory response that occurs. And I think, just getting back to the pathophysiology, I think it's also, there's another paper, I believe it was 2004 in Blood, by Michael Jordan, not the basketball player, but a pediatric oncologist who was training at the time in Pippa Merrick's lab at the University of Colorado. And he modeled like these patients in mice. And one of the things he did was he took mice that were wild type or normal in their genetic makeup, and mice that were completely deficient in perforin. So that's that protein that's important in that pathway, these kids who get it in infancy. And those perforin deficient mice in the mouse colonies are perfectly fine for the most part until they get the wrong infection, in this case, a bug called LCMV. And those mice, when they get that infection, will die within 10 to 14 days. Okay. But the interesting thing, and I think here was really kind of groundbreaking work and just getting us to think about this in this way, was that in those mice, in those perforin deficient mice, if you remove the CD8 T cells from those mice, these cytotoxic CD8 T cells that are there to kind of help mop up the infection, the mice don't clear the infection as well as the wild type mice, for example, but they don't die. Similarly, in this particular model, and this may not apply to all cytokine storms, but at least in this perforin deficient model, if you block interferon gamma, one of these pro-inflammatory cytokines, the mice don't clear the virus quite as well, but they don't die. And so this concept that you can have a viral infection, for example, that's triggering a cytokine storm, but it's the immune system that's killing, in this case, the mouse, and likely similarly in the host. So I think it's a really important concept, not just for COVID-19, but for other infections, that yes, we need to treat the virus, and treating the virus will likely lower the severity, for example, of the cytokine storm that's ongoing. But you can still have a cytokine storm syndrome despite treating the virus.
Right.
And so it's great in COVID-19 that we're trialing all these antiviral drugs. That's good. We need to find something that works, and hopefully we do sooner than later. But at the same time, if there's evidence either clinically or by laboratories or what we know for other cytokine storm syndromes that that's going on, then we need to treat that as well. We need to recognize that and treat it.
Absolutely.
And I got a little distracted from your question again. I did have an answer for it, but now I've kind of gone off on a little bit of a tangent there again. If you could bring me back in.
No, I was just, we're just trying to make understanding, and we'll refocus on the rheumatology, but I was just looking at that connection between the ARDS and the cytokine storm, sort of, is there a chicken or egg type thing, and which comes first? But no, it's I think it makes very good points there in terms of sort of this unique intersection or between virus and inflammation or immune response and what you deal with first. I think it's a fascinating wrinkle that we don't normally think about when we hear something like a virus. We kill it, get rid of it, but it's such a unique ecosystem.
I think another, if I can interrupt, another kind of interesting way to look at this is that, let's say have a relatively normal immune gene repertoire or a normal human host, and we get infected with, let's say, a virus, influenza, for example. Your immune system is set up to respond to that, right? We've been fighting pathogens through the millennia,
right?
And hopefully your immune system, responds to whatever virus it is and begins to clear that virus. But at the same time, your immune system is hardwired to shut itself down, because otherwise you'd be in a chronic state of inflammation or one giant lymph node, for example. But what's thought to occur, getting back to the mouse model and the humans, is that in cytokine storms, there's actually a subtle or not so subtle defect in your immune response. So it's not like having a great immune system puts you at higher risk of developing cytokine storm. It's really just the opposite. There are subtle defects that you probably tolerate for most of your life until the wrong organism comes along, or the wrong situation of leukemia or an autoimmune disease or autoinflammatory disease.
Right.
But it's really the subtle defect in the immune response that doesn't allow it to ramp itself down. And so I think that's another really important concept to push across. Extremely
important. You're right. Definitely. Thinking about, some of the things that you mentioned in terms of treatment, you talked about the sort of the pressors, the antihypertensive agents. You talk about sort of the older school, the steroids with the immunosuppressant, or the sort of the cytotoxic immunosuppressant type drugs. Then you talked about some of the fascinating results that you had with the IL-1 receptor antagonist. And I was doing a little reading on the side that some of the other things that are being talked about now, or maybe experimented with, anti-IL-6 antibodies, anti-GM CSF. A lot of this, takes me back once again to sort of my own days in rheumatology, about sort of the stepwise process of, with early, say, rheumatoid arthritis, and as it gets worse, we go to the bigger guns. In this case, do you typically start with the big guns early on, in the sense that, as I was saying before, there's a lot of IL-1 being pumped out here, but there's also IL-6 and tumor necrosis and so forth and so on. Are there, in the pharmacotherapeutic basket, is this something where we start with the more basic stuff, or does it make more sense in what we're seeing with whether your patients or some of what you're hearing on some of these other fronts to be more shotgun, let's say, as opposed to sort of sniper rifle with these cascades?
So even before we get to treatment, maybe we should talk a little bit about how we recognize or diagnose these patients.
Okay, please.
And so there are several diagnostic or classification criteria out there for various cytokine storms. Some are very specific to various diseases. Angelo Rovelli in Genoa, Italy, for example, has really championed this for both kids with systemic juvenile arthritis and for lupus patients. And that's good, particularly for clinical trial work where you really want to have defined populations, for example. And there are some more kind of broad criteria, the HLH-04 that the oncologists developed primarily for these familial kids that are often used for the secondary forms, but are often too restrictive. And some of the lab tests don't come back in a timely fashion. So they're less helpful in a lot of the secondary forms unless you're incredibly ill and you meet all the criteria, and then you don't probably need the criteria anyway. But there's also something called the H-score. Laurence Fordet put that out. It was based, I think, from best I understand, primarily on adult cancer patients. And sometimes it's also hard to get all the features, whether it's clinical or laboratory features you may not know to be able to use those criteria, but they're nice in that they're broad, so they potentially cover all. We've done some work even with just a ratio of the serum ferritin, which is almost always elevated in these cytokine storms.
Okay.
It's also a really cheap and readily available test for the most part. It's fast. It's, you know, if it's low, it's actually a marker of some types of anemia. And so it's been studied for or used for a long time. But in the studying the cytokine storms, it's often incredibly high in the tens of hundreds of thousands. But once again, this particular virus has thrown a different angle at us in that, you know, the ferritins are elevated in these patients with cytokine storm syndrome associated with this SARS-CoV-2 or COVID-19 infection. But they tend to be in the thousands range, 1 to 2 to 3,000. They can be higher, but they tend not to be screaming high. And no one knows exactly why. But anyway, the ferritin outside of the realm of COVID-19 is really a pretty simple sensitive screen. It doesn't prove you have it, but it would get you thinking about some of the other laboratory features and clinical features that we see in many cytokine storm syndromes, whether it's low platelet count, low lymphocyte count, markers of liver inflammation going up, markers of something called DIC or disseminated intravascular coagulopathy, which subsets of sepsis patients develop, for example, which gets you into bleeding and clotting abnormalities, which once again, this funny COVID-19 infection, there's reports of a lot of clots, whether it's in your central nervous system, your brain, or in your lungs, or in your deep veins. This seems to be a major feature of this particular virus. So diagnosing this is still kind of a challenge. I think my personal opinion, this is beyond COVID-19, if you are sick enough to be in the hospital, and I know that's a moving target with COVID-19 based on just need, but if you are sick enough in general to be admitted to a hospital and you have a fever, even if you know why you have a fever, like you know you got such and such a condition or infection, to me, it's a cheap, simple, readily available test. You need a serum ferritin. If it's low, great, you can ignore it, maybe check it again in a couple of days if it's not getting better. If it's high, then you need to start working them up and theoretically potentially treating them, because we know the sooner you treat cytokine storm syndromes, the better the outcomes. So that's kind of a more broad thing other than COVID, but diagnostically, a good place to start is the serum ferritin. And beyond that, then you can add a variety of other markers. And it's not 100% sensitive, but it's pretty sensitive overall. But then, you know, so let's say we, and it's important to point out that in medicine, we have this thing called Occam's razor, this kind of dictum where we see a patient, we don't necessarily know what's going on, but we look at all their features, all their labs, all their history, and try to come up with one kind of underlying diagnosis to explain it all, instead of 3 or 4 diagnoses that kind of mishmash and we're probably not treating the right thing. But unlike that, with a cytokine storm, it's kind of the opposite in that you can have frank sepsis. You can have bacteria growing in your blood that are making you incredibly ill. And a subset of those patients will have a cytokine storm on top of that. Or you can have systemic lupus and have low white count, but maybe have a cytokine storm on top of that. Or leukemia, you know, and all the things you suffer from having that cancer, but then have a cytokine storm on top of that. So you have to, number one, recognize the cytokine storm and therefore be able to treat it. So I think that's another important concept. But getting to your question about, you know, the various therapies that are available, and there's a laundry list now of potential therapies that have been tried in various other cytokine storms. Part of that is that, you know, that's why we have this umbrella is MAS is not necessarily viral induced HLH. It's certainly not COVID-19, what we see in some of our systemic JA patients, for example. So they're all slightly different. And I think it's important maybe to keep some of those names, but just recognize that it's under an umbrella of a cytokine storm in which many of the features are shared, but not all. And so we're, you know, we're kind of in this place where we have this new infection, which is even different from SARS and MERS and other coronaviruses that we've dealt with more recently, and different from influenza, but they're all capable of triggering the cytokine storm. And so I think we need to use our experiential knowledge to help potentially treat these patients. Now, in general, we want to have people in clinical trials so that we can really learn, because anecdote, while it may be valuable and may be a reason why you'd want to do a clinical trial, for example, doesn't always pan out. And so it's very hard for physicians in general to recommend treatments without knowing. But I do also think, and this is somewhat, relatively unique to pediatrics, and particularly pediatric rheumatology, we don't always have the guidance of multiple randomized, double-blinded, placebo-controlled trials to guide us. And so in patients who are in front of us, whatever the condition is, we often kind of resort to anecdote and hearing from our colleagues, like, this worked. Like, that's kind of how anakinra got started for systemic JA, for example. So, they're not invaluable, but in the setting of a pandemic, particularly in hot spots where unfortunately people are dying by the hundreds or thousands, that not everyone can be enrolled in a clinical trial. And it's hard to wait the 2 months or however long it's going to take to get some of these results back. So people, out of desperation, are turning to some of the therapies that we've used. And similarly, many of them are now being clinically trialed, which is great. We'll get a more definitive answer. But a long way to get into your question. So in cytokine storms in general, not COVID-19, but in cytokine storms in general, corticosteroids was one of the first types of medicines that we learned helped early on. And corticosteroids are kind of our best friend and our worst enemy. They are phenomenal at treating inflammation. They treat almost all aspects of the cellular immune response, whether it's the old innate immune system like monocytes, neutrophils, or the more adaptive, like the lymphocyte populations. But they're very good at broadly suppressing your immune system, right? Which is great at treating inflammation, but not so great, if you get secondary infections or the laundry list of side effects that come with corticosteroids, everything from hypertension, diabetes, you name it, even in the short term. So they are good and bad, but we do use them quite a bit for many other secondary cytokine storm syndromes. There are kind of other broad drugs which more target the lymphocytes, the adaptive immune system. These are drugs that circle back to this NFAT transcription factor family that I got interested in early on as a researcher, tacrolimus, cyclosporin, for example, calcineurin inhibitors. And they really, in part, disrupt the ability of these cells to function. And in part of that, it's even releasing these cytokines. Many of them are dependent on this NFAT family of transcription factors to be made. So those are kind of two broader approaches. There's the chemotherapeutic approach with etoposide, dexamethasone, and other corticosteroid. And initially they had used even cyclosporin, but they've kind of come away from that. And this, has got about a 60% survival rate. But some cytokine storm syndromes out of various case series around the world, particularly in adults, the mortality can be quite high, much higher than that. So, and for the familial form, if you get it, there's a good chance you will not survive unless you get, prior to something recent, get this protocol of etoposide, this chemotherapy, followed by a transplant. 60% survival is better than 0% survival. But maybe for these secondary forms, etoposide is not certainly the first line drug that we're going to go to nowadays. There is a FDA-approved drug for refractory familial, or the genetic form of this disease. The paper is still yet to come out, as best I know, but I keep hearing it's coming out soon. And that's an antibody, emapalumab. All these drugs that end in MAB stands for monoclonal antibody. And emapalumab, kind of championed again by Michael Jordan and people who studied the role of gamma interferon in various cytokine storms, it targets this protein interferon gamma. And it is FDA approved for the refractory. So it's it's available. It's being clinically trialed in Italy and potentially elsewhere. I don't know all the trials that are ongoing, but I know it's being trialed in Italy right now. one potential concern, and this is more theoretic than anything, because as much as myself and other people are, scientists, I'm always kind of amazed by anecdote and what we see. You can think yourself into a corner sometimes of what's going to work, what's not going to work, but in the end, it also comes down to just what does work when you try it. But anyway, so it's likely, my guess is it'll be beneficial for COVID-19. We'll have to wait and see. There is some concern that targeting this protein gamma interferon, like we evolved these cytokines, whether it's IL-1, TNF, gamma interferon, IL-6, IL-18, to fight things like infections.
Sure.
So, they're not perfectly safe, but, and gamma interferon may be really important for clearing intracellular pathogens like many viruses, but you kind of weigh that. Let's say it does make them kind of like the mouse model that I was talking about. You weigh the potential downsides of not completely curing the virus versus keeping a patient alive who's dying from a cytokine storm. So anyway, so that's one drug that is at least FDA approved for a familial version of cytokine storms. Anakinra may be just anecdotally and mostly case reports and case series, including some of our own work, one of the drugs that's gone to first, and for a lot of reasons. One is we've just kind of used it and published on it. And IL-1 is kind of a central player in a lot of inflammatory responses. It's even upstream of interleukin-6, for example, in some scenarios. So, and this particular drug, anakinra, this recombinant human interleukin-1 receptor antagonist, and in full disclosure, I'm part of a clinical trial using that drug that's sponsored by the company who makes it, Sobi. And I've actually consulted for them in the past, as well as some of these other companies that make these agents, but just for full disclosure. But anyway, I still, to my true believe this may be one of the safest and potentially most effective, at least to start with, because it's got a short half-life. So even if it was dangerous, which it tends not to be, it does have some known side effects, including rare liver enzyme elevations at higher doses, low white counts, and platelets. But for the most part, it's very well tolerated, other than if you give it subcutaneously, it does burn. But in the setting of someone in the intensive care unit, that's usually the last of your concerns, or lower on your list of concerns. But it can also be given IV, although that's somewhat controversial. But anyway, to me, it's kind of a good place to start, because if it works fast. It's got a huge therapeutic window, a short half-life, a good safety profile. It's got over 7,000 patient years of safety data from the rheumatoid arthritis studies and others, for example. And that's being trialed in Italy. We're going to do a small trial here at the University of Alabama at Birmingham, hopefully soon as we can get it through the Institutional Review Board. So that makes a lot of sense. Tocilizumab has gotten a lot of attention with COVID-19. It's a monoclonal antibody, MAB again, that binds the interleukin-6 receptor and blocks IL-6 signaling. There are also antibodies out there that block interleukin-6 directly. But tocilizumab got a fair amount of attention because this pandemic really started in China. And to the best of my knowledge, the IL-1 inhibitors aren't available there for the most part, whereas tocilizumab was. The other thing is that it's relatively straightforward to measure interleukin-6 in the blood, where that's harder to do for interleukin-1, for example. So that's what it was kind of first being used, and now it's being trialed in many institutions. So once again, hopefully we learn from that sooner than later. It's got its side effect profile is a little bit slightly more concerning than IL-1 blockade with anakinra, for example. But once again, you're weighing the benefit of helping people versus the potential side effects, and still not knowing which is the key or central cytokines that we need to go after. I will say the amazing thing to me, and I still don't quite understand this, is that when you have these cytokine storms, it's a mess. You've got all these guys, IL-18, IL-1, IL-6, TNF, gamma interferon, going crazy. How are we going to stop all that with a targeted approach? And yet, anecdotally, when we treat these patients, whether it's any of these agents, if they work, they bring the regulation all back under control. So as much as it took to kind of get it out of control, sometimes it's not as complicated to get it back in control, which is good news, I think, for all of us. So there are a variety of directly targeting agents, which theoretically should be safer than broad spectrum things like corticosteroids or things like cyclosporin, for example. There are also approaches of intravenous immunoglobulin, which modulates the immune system. So I think those are being trialed as well. There are antibodies to a receptor on lymphocyte CCR5 that is also one of the co-receptors for the HIV infection, for example, that are being trialed. I'm sure I'm missing plenty, but there's a lot of good ideas, and some have more prior practical experience in other cytokine storms than others, for sure. But hopefully sooner than later, again, we learn what's valuable. There are even things such as kind of filtering the blood approaches, whether it's plasmapheresis, which my colleague in Pittsburgh, Joe Karkilla, uses quite a bit in children with cytokine storm syndromes. And you're going to remove both pro and anti-inflammatory proteins in that process, but theoretically in that state you have more pro than anti, and so that's it makes sense, and anecdotally it works. So there are a lot of potential approaches here, but we're just in the state of a pandemic where we don't know what's going to work and what's not. And I'll say what is going to be highly controversial, but at the end of the day, my gut feeling, or my knowledge base, and talking with other people who are smarter than me for sure, who know about this stuff, is that it's likely that several of these approaches may be beneficial. And then the question comes down to a worldwide pandemic where millions and millions and millions of people are going to eventually become infected with this virus. Is not just cost, but are they going to be available at large numbers? And my guess is if some of these therapies prove beneficial, and this is not going to be for everyone. This is not going to be for people at home who are clearly asymptomatic, for example, or have a horrible case of the flu, but are not requiring respiratory support, right? I don't think, at this point in time at least, any of those patients should be treated for a potential cytokine storm. But this is likely to be for people who are sick enough to be admitted to the hospital, who have evidence clinically and by labs, for example, of a cytokine storm. And that's the point you want to treat them. That's not to say you should give up on them if they get to the intensive care unit, or if they require intubation and mechanical ventilation, but to treat them before they get there. We know from some of our data and others that you're likely going to respond better the sooner you get the therapy for the cytokine storm. And that's still, it turns out, maybe 20% of people who get infected with this virus require hospitalization. It's a large number, and maybe that 20%, we'll see what the genetics bears out, because people are doing genetics on all these patients too, whether it's whole genome sequencing or other approaches, whether we start seeing some of the same mutations we see in other types of cytokine storm syndrome showing up in those who are sicker with this. But in a subset of patients, i.e. those who are sick enough to be hospitalized and have features of cytokine storm, this is not, cytokine storm treatment is not going to help a 94-year-old with hypertension and diabetes who does not have a cytokine storm. Now, they could have that on top of it, and sure, they should be treated for that if they have it, but there's going to be a lot of people who unfortunately may succumb to this virus that we can't help by this approach. But in a subset of patients, and I don't know how large this will be, a cytokine targeted approach may be very, very beneficial. But like I'm predicting, and hopefully I'm wrong, if some of these therapies turn out to be good, their costs, these biologics in general, tend to be very high. And that could be somewhat dealt with, I guess. It's way above my pay grade how you would change that. But I think even being able to ramp them up, they're not always trivial to make. And some of these companies are not as big as others. And so my guess is we're not going to have enough to go around. One thing we do have enough to go around is corticosteroids. And they work for other cytokine storms. And this is why I realize this is highly controversial. And once again, I want to say this is not for people at home. And this is not for just the average patient coming into your hospital. It's really, you have to have some kind of, it may not be a clinical trial. And number one, that should be our ultimate goal, is getting people in clinical trials. But we can't always do that, even at places that have trials available. Number one, they may not meet the criteria, or they may not want to be in it, or whatever. Or there's just being overwhelmed, whether it's in New York City or Northern Italy or Philadelphia or wherever. It's hard to see people in front of you dying. And if you know you have a cytokine storm, you potentially could treat them, but you don't have even the drug available to do it, then what do you do? And so hopefully someone will do a clinical trial with corticosteroids. We're trying to propose one. Whether it gets funded or not is a whole other issue. Maybe others will try it, I hope. But because the World Health Organization has kind of reviewed the SARS and MERS and some of the influenza outbreaks where the data is kind of all over the place, whether it helps, doesn't help, makes things worse. They're very cautious about it.
Mm-hmm.
And I'm not saying that's wrong. I'm just saying that, that's what we're kind of up against.
Right.
And I do think this particular coronavirus is different even from SARS and MERS. It's definitely different from influenza.
Sure.
And anecdotally, this is all anecdote, until we do a clinical trial, we will not know.
Yeah.
But people are resorting to corticosteroids at kind of moderate doses, like 1 milligram per kilogram per day of some of our glucocorticoids. And we'll see if they're beneficial. But in the end, if any of these anti-cytokine approaches work for patients, the subset of patients who appear to have a cytokine storm, then my guess, I could be totally wrong here, is that corticosteroids may be what we ultimately turn to on a broader scale.
I mean, it sounds logical in the sense, they're widely produced, they're cheap, they do a pretty damn good job at shutting down the immune system. So it's going to be, it'd be quite interesting looking into the crystal ball. But along those lines, while I have you, and obviously not looking for medical advice for anything, but could you, based on your lupus experience, give us your top line thoughts on hydroxychloroquine and everything that's going on in the press nowadays regarding that?
That's also a very hot topic and political and beyond that. So
absolutely.
Hydroxychloroquine is a valuable tool in our toolkit for some of the diseases we treat, including systemic lupus erythematosus and some of our other skin-related autoimmune diseases like dermatomyositis, if anyone's ever heard of that. But it's an interesting drug. I mean, it turns out, there are some great papers where, when you join the Army, you give up a lot of things, including your blood. And so people were smart enough to go back and look at patients who had a positive anti-nuclear antibody or ANA blood test, which is one of the hallmark features of lupus, but it's also very non-specific, like 10 to 20, 30% maybe of the general population may have a low titer ANA. But it's almost impossible to have true lupus without a positive ANA. So anyway, it turns out that, depending on who their physician was, some of those patients who entered the Army and had their blood drawn and had a positive ANA, their physicians, put them on Plaquenil. For the most part, in a patient who's not deathly ill, it's a relatively safe drug. If you're on it for 5, 6, 7 years at a certain dose, you run the risk of having a retinopathy or damage to the back of your eye, and you get screened by the eye doctor periodically for that. But that's primarily it, in terms of side effects. We don't see a lot. There's a lot of concern now with arrhythmias and these QTC changes, particularly in people who are very ill and or in combination with other drugs like azithromycin who may contribute to that. And there are some reports coming out that is being seen. Now, these are all essentially non-trial data, but concerned that they may be doing harm. It's theoretically not so much an immunomodulator, to the best of my understanding, in the cytokine storm syndrome, but inhibiting the virus and it's part of its replication pathway. And so, great if it's an antiviral. I will be very personally surprised, and this is just my own kind of gut feeling or gut knowledge, is I would be shocked if it has a significant impact. It may have a mild impact. And then we also have to worry about, if it's not available for lupus patients because we're using it to treat everyone with COVID-19 and it's not doing that much. And some of our lupus patients, it may be in short supply for them, and them having a flare of their disease is not good either. So those are kind of things you weigh against it. But I will be personally surprised if it turns out to be kind of a home run here. It may shorten the day of illness by a day. I mean, shorten your illness by 1 day or so. I have no idea. My guess is it's not going to have a dramatic effect. But because, case series get attention, it's really kind of gotten a life of its own. And we'll see. I mean, I could be totally wrong. Maybe it is the next great drug, but I'm in treating lupus even, this is not an antiviral effect or rheumatoid arthritis or some of the other diseases where it's used. It's helpful, but it's not your go-to drug. It's not the first drug you use.
Sure. No, I appreciate you give your thoughts on the matter. It's just as you're saying, it's politically charged, it's mainstream media charged, and I just thought an expert like you opining for a couple minutes would be very useful. Final question: what's next for Dr. Randy Cron? What do you have planned? Any other big clinical trials, conferences you're going to be speaking at, new research projects you could talk about? Take us out on that one, if you would.
Yeah, myself and a lot of others, we've been, the NIH, or National Institutes of Health funding, which is the primary funder of research in this country, has not been great for a couple decades now. It's not, in the Reagan years, it was pretty bad. In the Clinton years, it was really good. And it's been really challenging. And so, although I've been able to get some small grants, it's even hard for me to get grants on this topic.
Gotcha.
I'm banging my head against the wall. But I'll do whatever I can. We have a small trial up and ready to go here soon, hopefully, to study a small number of patients who are randomized to anakinra versus standard of care. And if the patients in the standard of care arm are not doing well at 48 hours, we can switch them into the anakinra arm. And we're going to look at the genetics of that small cohort as well.
Okay.
So that's one thing. And like I said, we're trying to write a larger multi-site trial that will likely be looking at corticosteroids. Whether they buy that or not, or fund that, will determine whether we go down that pathway or not. I'm still really interested in the genetics of this disorder. And what we're currently doing in the lab is taking patient mutations that we identify in patients with secondary forms of these cytokine storm syndromes that occur later in life, and putting them back into natural killer cells in the lab and saying, okay, yeah, this mutation disrupts this. And ultimately, I'm trying to get Ed Behrens and other people who do mouse models of this stuff to even kind of have like an in vivo model, or a live disease model where these mutations are studied, so that we can either prove or disprove this concept that having heterozygous or single copy mutations in these same genes that we see in the familial form contribute, at least in part, to why some people develop cytokine storms and others do not, as well as trying to identify novel genes. And we have some progress in that area as well, including my son working on part of one of those projects last summer as a high school student. So
excellent.
Yeah. So that's kind of where I'm headed. I mean, there definitely needs to be more clinical trials. Most of what we're doing is seat of our pants again, on the larger scale even. And so in the end, I'm not a clinical trialist. I don't pretend to be. And I rely a lot on Dr. Wynn Chatham, who's an adult rheumatologist on the UAB adult side, who early on bought into this whole thing. And has really been a champion and my partner in crime, at least from the clinical aspects of this. He's also, a really bright guy, understands the science and all that too. So, but he's really been a strong partner in this effort to help patients with cytokine storm syndromes, wherever they may be.
I really appreciate that. That's outstanding. For everybody that's going to be watching on the YouTube link or listening on the various podcasts, we've been taking this time to talk with Dr. Randy Cron, Professor of Pediatrics and Medicine at University of Alabama, Birmingham, Director of the Division of Pediatric Rheumatology and Pediatric Rheumatology Fellowship Program at Children's of Alabama, and the Alabama chapter of the Arthritis Foundation and Endowed Chair in Pediatric Rheumatology. Pick up his book, Cytokine Storm Syndrome, because it's probably the leading text, the first of its kind, to address this really unique disorder, and that is extremely timely. Randy, thank you for not just taking the time to come on the show, but and share your knowledge, but for doing what you do, because it is such a specialized thing that we really all need to learn more about, especially in the middle of this pandemic, and of course beyond COVID, and in all areas that the cytokine storm is a medical topic, and really, as we say on the show, thank you for moving the human story forward on this front. It's really amazing work.
Well, thank you for having me. And like I said, I feel more like anything than a cheerleader for this. And shows like this, Ira, I think are really critically important just to get the word out there. I'm not going to be right about all this stuff. I may be right about some of this stuff, but hopefully we all learn and study this more.